Hi there. First of all, excuses. I was invited to start a thread on Patient Safety Hub, but with the weekend, so I'm just trying to adjust it slightly. With the weekend and several balls in the air, I just didn't really have time. I wanted to discuss safety in outpatient hysteroscopy. There's several topics it could discuss. Nurses not being advocates, informed consent. There's so much to this, so many issues. There could be hours of content, but I wanted to try and focus a bit more on the safety aspect. I know I will divulge off slightly, but I'll try and broadly keep it on safety. So let's go for a start. For quite often they say it's much safer in outpatient hysteroscopy. Well, let's put the GA to one side for discuss that for 1 second. Is that unfortunately, yes, 1 in 100,000 death rate. That's what the Royal College of Anaesthetists say. It's probably a bit safer than that because it's elective and it's so short, so there's no issues with blood clots that you tend to get with longer GAs. Now, I have seen a study that says that actually there is no increased complication rate for diagnostic only. Now, the caveat with that is quite often what starts off as a diagnostic goes, oh, there's a polyp there, we'll just get it. So the issue with that for outpatient is this is a 5mm outer sheath with a pair of scissors on. And despite them saying there's often not inclusions, well, that doesn't appear to be as normal as said. How many cases? I know one woman close to the family, she said, quote, they were scraping me off the ceiling when they tried to remove a polyp. So operative is safer. However, it's possibly up to 2% in procedures like myosure, which is a blade on a 5.5mm rod. The issue is that at the current situation that women are having perforations and they're not being put on a bed and monitored and looked after. They're simply they're given 5 minutes extra to recover, told quite often told to get out of the clinic. We know cases where they've been wheeled out on office chairs. So, and I also know of another case where a 2.7 calls a false passage, and the most sympathy she got was, you've had a shock. Adverse events are not being monitored, reported. That's the big issue, that there's no paperwork. So outpatient hysteroscopy looks safer than it is. Also, one hospital, I won't name them, actually have had, during a trial called the VAST trial, actually had an infection rate of 5%. Now this is for diagnostic, which is far too high, but did they do any investigations what this infection was? No, they just said they must have brought it in with them, and they didn't use sterile gloves apparently. Now I don't know whether the hysteroscopist did or whether it was the other accompanying staff, but at 5% is possibly, if it's something like, don't know what it is, if it's something like HPV, then it's potentially causing cervical cancer. Also, the pain in the outpatient hysteroscopy, it's told us it's not a big issue, or they get over it. Well, if women aren't being able to go for further investigations and I mean general, to the hospital, for not just hysteroscopy but for smear tests and just basic fee of the hospital, then how is that safer? So it would appear that the safety aspect may not even be there because of the amount of women not able to access further treatment compared to the risk of a GA, although that's why the campaign is heavily pushing for sedation. There have been complaints on Care Opinion where it was paracetamol or a GA. There has to be a compromise, there has to be something in between. And the thing is, it's actually safer. It would be safer to do it that way than to do the current outpatient hysteroscopy. Now, I've heard the mantra many times. It's usually well tolerated. Well, that isn't what the stats suggest. Now, the campaign says 1 in 4 have an issue, but the studies I've seen, like the one in Canada, the one in Cairo, and when you take the one in the VASH trial that says 1 in 4, when you look at how many women actually withdrew from the study and the fact that they swapped the postmenopausal and the menopausal around, i.e. it's normally 60% postmenopausal and 40% non, they actually swapped it around. When you take into account the statistical deviations, it appears again to be coming out at 33% 1 and 3 are having severe pain, and again that's a VAS over 7. So when you're looking at when this should possibly be stopped, it's quite high. The reason it's not is because of money, but the financial issue is just stupid because they're getting paid twice for failed procedures, which is why some women are being put through 2 or 3 times. That isn't particularly common, but it has been known because you get paid for a failed procedure. So if these outpatient hysteroscopies were being stopped at an appropriate pain level and they weren't being paid twice for a failed procedure, it would actually work out more expensive. I know there's an issue with access to theatre time, etc, but it's actually more expensive. Is it more expensive now? No, but if it was done properly, it would actually be more expensive, which is the biggest issue why it's not being done properly. And when they talk about pain in outpatient hysteroscopy, they tend to talk about diagnostic, and you can get, with patient selection, very good percentages. But no real screening is done because the amount of women that should go for it are relatively small. Now, if you've had a leaf cone biopsy, you probably need a local, but it's possible, or not given birth naturally, or had a C-section, again, just filling the womb with saline solution. If you had a C-section, that increases the risk of pain. Postmenopausal women really, in my view, shouldn't be candidates for outpatient, simply because if they do have cervical stenosis, sorry about my pronunciation, that it's really unpractical to overcome it in an outpatient situation, and is extremely painful if they do, and dangerous if they just force through the scope, which is what normally happens. There's no proper monitoring of adverse events, because we know of cases where they've left an outpatient hysteroscopy and literally had to walk around and go in the A&E because they've just been kicked out and they've had to go in the A&E for help. And in cases they have been kept in overnight, however, there are no facilities, which means in theory someone could go in and then find that they're on a bed in a corridor overnight for something so intimate. they also, because the cuts in the psychosexual health counselling, no one's actually monitoring how many women are actually needing help or being offered help or know where to find it. My last thought, and then I'll finish, that scope manufacturers are having an undue say on how procedures are run. Medtronic have a promotional video, and I was also told by a rep for Medtronic that they don't need to use local anaesthetic, i.e. a cervical block. Well, for 5mm, it darn well do. There's no way you can. Only a very few women that have given birth naturally, and within fairly recent, I would say, would actually be able to tolerate a 5mm well without any anaesthesia, local anaesthesia. But they're telling clinics not to, or they don't need to, which means they're when they're demonstrating the equipment, they're telling them not to. Plus, Medtronic only have one female, and then none of them are medically trained, so they're having to have a male, non-medical male present to observe before they can pass off the equipment. I find that unethical, and in my view, the company should be stopped and forced to actually employ medical personnel. At least Hologic do, although there are still major issues with Hologic because they push their ablation for outpatient, and I know they say, well, with a fundal block the pain scores come down. And no, they're still too high. There's no ethical reason to be doing ablation in outpatient without, there needs to be sedation for that. That's just utterly disgusting. And again, the ablation, the failure rate of that, obviously the older the woman, the more successful it is, but that varies from 60 to 30% failure rate. Let's call it 50. So quite often a woman will need a hysterectomy later anyway. So how is that safer? And women have died. Women have died from ablation. It's not, I wouldn't say it's dangerous as in compared to other procedures, but doing an ablation and then having to do a hysterectomy later, it was safer just to do a hysterectomy. There are major concerns with ablation with informed consent for that, and the MyoSure, again, the infection rate's 4% with that, and the perforated root percent I've been told is as high as 2%. So again, this is not something you should be doing in outpatient and thinking you can kick the woman out after. Also, the recovery time can be up to 3 days. So although the bed rest is not recommended, they shouldn't be advised they can just resume normal activities after. They shouldn't. There's so many issues around safety with this. It's the fact that it's not being monitored and recorded when adverse events are happening, and they are happening on a regular basis. And it's all to do with cost cutting and the fact that if it was run properly, the amount of women that would be selected for outpatient are quite few, and then if it was stopped at an appropriate level, should they be paid for failure? So by the time you add all this in, is it actually cheaper? Oh, and nice. They mentioned trying to avoid ultrasounds. No. That's dangerous. NICE need to be brought up on this. That's dangerous. You need to do a transvaginal ultrasound because it looks on the outside as well as the inside. Hysteroscopy should not replace transvaginal ultrasound. It should be used in conjunction. Also, that I briefly mentioned before, the pain scores can be quite low for purely diagnostic. However, when you said, oh, I'll quickly remove a polyp, and they'll go, well, we'll do an endometrial biopsy after, which are famous for being painful, and women can still have post-traumatic syndromes from them, that actually you're just engaging in semantics quite often when they say, look at these figures. Well, yeah, but you've stacked the deck in such a way that it comes out in your favour. So I'll leave it at that. I'll hopefully do a few more other videos later on other subjects, but I'll try to keep it more on safety on this one. Thank you, bye.